Good afternoon. Welcome to the workshop, Secondary Cancers After Transplant. My name is Marla, and I will be your moderator for this workshop. It is my pleasure to introduce today's speaker, Dr. Alison Loren. Dr. Loren is Chief of Hematology Oncology and Professor of Medicine at Perelman School of Medicine at the University of Pennsylvania. She is also the Director of the Blood and Marrow Transplant and Cellular Therapy Program at Abramson Cancer Center. Dr. Loren specializes in hematologic malignancies or blood cancers, and her clinical and research interests focus on outcomes after transplant, fertility preservation and pregnancy, and long-term survivorship. Please join me in welcoming Dr. Loren.
Thank you very much. It's great to be here, and I really appreciate the BMT Survivorship Symposium and the entire team who's put this wonderful workshop together, and it's just an honor to be here and to be speaking to all of you who are the bravest and strongest people that I have ever met. And I just want to say that I get so much out of taking care of my transplant patients every day, and I thank all of you for all that you've taught me. I'm going to talk to you a little bit today about the issue of developing cancers after your bone marrow transplant, and just a little bit of terminology. What we're going to be talking about today is what we call a second cancer or secondary cancers. These are cancers that occur months or years after a bone marrow or stem cell transplant, and they are different from the one for which the transplant is performed. So if the transplant was done for a certain type of blood cancer like acute myeloid leukemia, and that same cancer comes back after transplant, we call that a relapse. But if a person develops a different cancer after transplant, we call that a second cancer. And people who have had hematopoietic cell transplants, bone marrow transplants, which we frequently use interchangeably, patients who have gone through transplants are at an increased risk of developing another cancer, largely because of the effects of high-dose chemotherapy, radiation, immune suppression, and also certain infections that can occur after transplant. And there may be certain genetic predispositions that make people more likely to develop their first cancer as well as the second cancer. So a few points I'd like to highlight. What I hope you take away from this is that it's important to know that it is common to have a second cancer after a bone marrow transplant, but the types of cancers that people get are different depending on if they've had an autologous transplant or a transplant using their own blood stem cells versus an allogeneic transplant, which is a transplant using somebody else's blood stem cells. And these risks hold true for pediatric recipients, for kids, as well as for adult recipients of transplant. It's important to know that there are things you can do about these risks. Screening and prevention are incredibly important and make a huge difference in long-term outcomes after transplant. And in addition to sort of making sure that you stick with your screening recommendations, it's also important to know that there are lifestyle choices that you can make that will reduce your chances of getting another cancer. And lastly, it's important for you to know that there's a lot of research going on in this area. We don't understand why some people develop cancers after transplant while others don't. And we're hoping that what we learn can help to personalize our approaches to reduce the risks for all of our transplant recipients in the future. So one piece of great news to share with you is that transplant outcomes are improving, and here I'm showing you some data from a study that was published about almost 15 years ago now, demonstrating that patients who received transplants in an earlier era in the 90s, comparing them to patients who had transplants just 10 years later from the 2003 to 2007 timeframe. And you can see in the first panel that patients who received their transplant in the 90s were more likely to die from transplant-related complications as compared to patients transplanted more recently. And then reflecting that, the likelihood of surviving a transplant is significantly higher in patients who received transplants more recently. So that's great news. However, what we are still seeing is that people who survive transplants don't live as long as people who haven't had transplants. And this graph demonstrates this pretty strikingly. So this study looked at patients who were at least 2 years after their transplant and followed them over time. And you can see in the first 2 lines, these are women and men who live in the United States. And you can see that their likelihood of being alive 20 or 25 years after the initial time point is still pretty high, greater than 90-95%. Whereas people who received donor transplants for allogeneic bone marrow transplants, only about 75% of them were still alive 25 years after their transplant. Now, that's a great outcome in some respects because, as you all know, patients who receive transplants typically receive them for life-threatening illnesses that they otherwise would not have survived even 1 year, let alone 25. But at the same time, this gap between people who were not transplanted and people who were transplanted, we're losing a lot of lives in that time frame, and we'd like to understand that a little bit better. This is another depiction of a similar concept. Essentially, this shows the likelihood of dying per year. And you can, of course, see that people who have not had bone marrow transplants, which is this bottom dotted line, have a pretty low chance of dying at any given time, whereas people who have survived 5 years or more after a bone marrow transplant are much more likely to die from some illness, and we'll break that down in a moment. But essentially what you can see is that having gone through a bone marrow transplant still puts you at high risk for dying from complications. And why people die after bone marrow transplants, it's still a sort of a heterogeneous group of causes. You can see that both for donor and autologous transplants, the relapse or recurrence of the original cancer for which the transplant was performed is the greatest cause of death. For people who receive donor bone marrow transplants, you can see that graft-versus-host disease is a significant issue. But again, highlighting the importance of second cancers, 5 to 10% of people who received donor transplants die from a second cancer. And in people who receive autologous transplants, it can be as much as a quarter of people who are dying from second transplants. So it's an important problem that we need to understand and try to work on preventing. So in general, second cancers after a bone marrow transplant are a significant risk. The risk of getting another cancer is between 4 and 11-fold higher compared to the general population. And in one study, the BMT sibling survivorship study, which compares transplant survivors to their siblings, 7.5% of transplant survivors developed another cancer as opposed to 1.6% of their sibling controls. So even within the same family, there's a higher risk. And the risk continues to rise. So even 15 years after donor transplant, the cancer risk is still significant. And we typically break these types of cancers down into 3 main groups because they really are different from one another. One group of second cancers is known as therapy-related blood cancers. Another group of cancers are lymphomas that are related to the transplant and immune suppression itself. And then the third group are what we call solid cancers, and these are cancers of the organs like breast or colon or skin or cervical. So they really are different kinds of cancers in different groups of patients. I'm going to talk about them one at a time. And the most important thing you can see in this slide is that people who develop MDS or AML, these are the therapy-related blood cancers, that typically happens pretty early after transplant, and then the risk sort of levels off by 5 years after transplant. And that's similar with these lymphomas, these post-transplant lymphoproliferative disorders or PTLDs, that also tend to occur very early, within the first 1, maybe 2 years after transplant, but then not at all after that. But the solid tumors, you can see, really kind of steadily rise over time, and they never really plateau. So as much as 4% of patients who have received a transplant at 20 years will have developed another tumor. The therapy-related blood cancers, which typically include blood cancers known as myelodysplastic syndrome or MDS, and acute myeloid leukemia or AML. And I think many of you in the audience will recognize these cancers because these are also a very common reason why people receive donor bone marrow transplants. These conditions can be triggered or caused by exposure to certain agents, such as chemotherapy and radiation. People who have received autologous transplants, people who have received transplant using their own blood cells, they have received typically a lot of chemotherapy and radiation before getting their transplant. And so the presumption is that their own blood stem cells may have become more likely to go on to develop these therapy-related blood cancers. As I highlighted before, these typically occur pretty early after the transplant, up until about 5 years, with a cumulative incidence around 2% at 10 years post-transplant. And as I mentioned, radiation exposure, and actually in the older days, we used to use a drug called etoposide to help mobilize or stimulate the blood stem cells. That's not very frequently used anymore, and this is one of the reasons that people who received high-dose etoposide as a mobilizing agent to collect the stem cells seem to be at higher risk. In contrast, lymphomas, which are known as post-transplant lymphoproliferative disorders when they occur in this context, almost exclusively occur in recipients of donor bone marrow transplants. And as I mentioned, these typically also occur quite early after transplant. They are nearly all driven by a virus known as Epstein-Barr virus, which is a virus that is in the herpes family of viruses and is the virus that causes mono. So some of you may have heard of this virus before. This is thought to be caused by the EBV virus, which lives in B cells, which are a type of white blood cell. And that EBV infection of B cells seems to drive the B cells to sort of overgrow or proliferate. In people who have not had bone marrow transplants, who have a normally functioning T cell population, T cells are another form of immune cell, those T cells, if they're working right, can block that B cell proliferation and prevent this type of cancer from occurring. But for people who have impaired T cell function, such as people who have had donor bone marrow transplants, solid organ transplants, people who have had liver, heart, lung, kidney transplants can get this. People who have had T cell depletion as a preparation for their transplant, either using antibodies like ATG or Campath, or T cell depletion as part of graft engineering, where it's a CD34 or a stem cell selected graft. People who have received umbilical cord blood transplants, people who have immune deficiency as a reason for getting the transplant. This is more often in children. People who have had mismatched or unrelated donors because the degree of immune suppression is usually greater. And similarly, people who have significant graft-versus-host disease, again, who need a lot of immune suppressive therapy, those are the people who are more likely to develop post-transplant lymphoproliferative disorders. These are not terribly uncommon. As much as 8% of patients who have received some of the riskier forms of transplants can go on to develop PTLD. In the old days, when I was training, these were actually very serious problems that patients often succumb to. In good news, we've learned a lot about these disorders, and we're learning how to surveil and monitor for these and to treat them often with a medication known as rituximab, which will prevent a full-blown lymphoma from forming. So we've made a lot of progress in understanding and treating this condition. I think the biggest challenge is the risk of solid tumors. And I want to emphasize here that I'm going to show you some numbers that are a little bit scary that show significantly increased risks of getting these different kinds of cancers after a transplant. That being said, it's important to recognize that there's a big difference between a relative risk and an absolute risk. So I know this is going to sound shocking to this audience, but cancers are not terrifically common year to year. And so a 2-fold increase or a 30-fold increase may still only be a small percentage increase, but it still is relatively uncommon, but the risks are still much higher than the average person. So I'd like you to keep that in mind as we sort of go through these numbers, that while they are striking and important and major health risks, it's not cause for panic. And again, there are things you can do to help mitigate your risks. So the risks of solid tumor occurrences, second cancers, seem to be a little bit higher in donor transplants, allogeneic transplants, as compared to autologous transplants, with the exception for autologous transplants being this therapy-related blood cancer risk, which is 20-fold higher, remembering, of course, that these myeloid cancers are quite uncommon in the general population. So this 20-fold increased risk still represents a small number of patients, but the risk is much, much higher. But you can see that in people who have received allogeneic transplants, they have about a 2-fold risk of developing some kind of solid cancer, and it's about a 1.4-fold risk for people who have received autologous transplants for cancers other than these blood cancers. And as I mentioned, the cumulative risk is significant and increases over time. There's no plateau. It never levels off. So even if you're 35 years after your transplant, you still need to pay attention to these risks. People who have received radiation, people who have chronic graft-versus-host disease with the attendant immune suppression that engenders, as well as the inflammation that tends to cause, people who are at younger ages when they receive their radiation therapy, people who have infections with certain viruses like HPV, which can cause cervical cancer or penile cancer, and hepatitis viruses, which can cause hepatic cancers, are all at increased risk. It also seems that the reason for the transplant might influence the risk of getting a second cancer. People who have transplants for acute leukemia seem to be at higher risks, for instance, than people who have severe aplastic anemia, which is not thought to be a cancerous condition. And so whether that has to do with the intensity of the therapy that people received before their transplant, or the way in which the transplant was done, or maybe genetic predisposition somehow to cancers in general, we're still trying to understand that. Even if you don't receive radiation as part of your transplant preparation, the risk is still significant. So this study focused only on patients who received chemotherapy-based conditioning with busulfan and cyclophosphamide. And you can see that patients who received their transplant for AML or for CML still had about a 3% incidence of some type of solid cancer at 15 years after transplant. So it's not just about the radiation, although radiation is certainly the biggest risk. And particularly if you are young when you receive the radiation therapy, you can have a significant risk in what we call non-squamous cell cancers. So squamous cell cancers typically are cancers of the epidermis, like the skin, the mouth, or the cervix, whereas non-squamous cell cancers are all the other cancers, breast, GI, et cetera. And so radiation is most strongly associated with pretty rare types of cancers like thyroid cancer, bone cancers, and soft tissue cancers like sarcomas, central nervous system tumors like brain cancer, as well as breast and melanoma, which is a non-squamous cell skin cancer. The presence of chronic graft-versus-host disease seems to mostly influence, conversely, the risk of squamous cell cancers. And again, that's largely thought to be related to the sort of inflammatory environment of chronic GVHD. And those of you who have chronic GVHD certainly can attest that skin and mouth and the vaginal area in women is very significantly affected. And so if you can sort of imagine a lot of inflammation and cell turnover, that probably is why there's a lot higher risk of squamous cell carcinomas in those areas in patients with chronic GVHD. For some reason, men have a higher risk of skin cancer. We don't totally understand that. Reduction in T cells seems to increase the risk of melanoma. And it does seem that myeloablative conditioning, people who receive very intensive conditioning regimens, may be at a higher risk as compared to reduced intensity transplants, where a recent publication suggests that perhaps people who have received reduced intensity transplants may have risks that are more closely mimic the general population. But I still think that those are people who need our close attention. I'm not sure that I would totally check out if you had a reduced intensity transplant. I think there's still a lot to be learned there. So this is just an example of the degree of increased risk that people have after transplants. So these numbers basically reflect the fold increase over the general population. So for instance, for the risk of lung cancer, people who have received a busulfan Cytoxan conditioned transplant, the risk of getting lung cancer is 2.6 times the general population. And so you can see these are not typically very common cancers. Liver cancer, thyroid cancer, these are not particularly common, and so their risks are significantly increased because of the exposures associated with transplant. But even so, breast cancer risk is still elevated. Oral cavity cancers are elevated. This is one of the reasons I'm always harassing my patients to go see the dentist. I always look in their mouths, but it's sometimes hard to see back there, and dentists can be an important way to surveil for these cancers. Some recent data about children and central nervous system or brain tumors. It's important to be aware, again, remembering that brain tumors are very, very uncommon. So a 33-fold increased risk still is only about a 5 to 10% chance of getting a brain tumor, but that's significantly higher than the general population in which these tumors are quite rare. And so we are learning that radiation exposure and also the presence of cancer in the central nervous system before transplant, for instance, patients with ALL, acute lymphoblastic leukemia, who had leukemia in their spinal fluid, seem to be at the highest risk for developing this particular type of cancer. And children are also at increased risk even if they've had an autologous transplant. And again, this is relatively more recent information where we're starting to understand that, again, because these kids were treated so young, developing a solid cancer 5 years or 10 years after their transplant, that means they're only 18 or 19 or 20 or 25 when they're developing these cancers, which, as you all know, typically cancers are diseases of the older population. And so it is a significantly increased risk because cancers are so rare in these young patients. And we're starting to learn, and this is largely based on Dr. Bhatia's work and others, that there's probably genetic predisposition to the risk of certain cancers. So we're starting to understand that there are genetic risks that may increase the chances of developing cancer, people who have genetic problems in their ability to repair damaged DNA. There's genetic variability in how we metabolize chemotherapy. There are some people who seem to be less able to metabolize the chemo as quickly, and so it sort of hangs around for longer, and maybe that causes an increased risk for cancer down the line. There's some studies demonstrating that a certain part of the chromosomes, known as telomeres, may be affected by treatment, and that can specifically increase the risk of thyroid cancer. And more recently, we're starting to learn more about a genetic tool called polygenic risk scores, which can help us better focus on increased risk patients who are at risk for breast, thyroid, or central nervous system cancers. And so what can we do about this? Well, we're certainly very actively engaged in trying to figure out safer ways to do transplants. And I think everybody on this presentation is aware of our efforts to try to reduce the toxicity of the therapies that we're offering. But in the meantime, and for those of you who have already had your transplant, which I suspect is most of you, what can you do about this moving forward? Well, number one is to be aware of your risks. And I've already mentioned, if you've had radiation as part of any part of your treatment, your risks are higher and you need to be aware of that. In order to prevent skin cancer, it is recommended that you see a dermatologist every year and have them check you out from head to toe. And in particular, if you have graft-versus-host disease of the skin, this is really essential. And just the risk cannot be overstated. You really need to have yourself checked out every year. Thyroid cancer, again, a rare cancer, but significantly increased in these populations, especially people who have received radiation. An annual thyroid exam or maybe even an ultrasound is appropriate. Checking thyroid blood tests does not necessarily exclude thyroid cancer. So somebody should lay their hands on your thyroid gland. It sits in your neck just below your Adam's apple. Somebody should examine that every year, or you can. And if you feel a little lump, that's important to report. Again, some people prefer thyroid ultrasounds, especially if they already have thyroid nodules. It can be hard to know whether they're cancerous or not, and an ultrasound can tell the difference. Thyroid nodules are very, very common, and many times they are benign and don't need any intervention, so that can be a helpful tool to distinguish those nodules. I already mentioned the importance of a good dental exam at least every 6 to 12 months. Many, many people after transplant have dental issues anyway because of the reduction in saliva production and the dry mouth. And so many of my patients will actually see their dentist 3 times a year because of that. And so it's good to make sure that they get a good exam as well. There is an increased risk of cancer of the esophagus, and so at this time there are no screening recommendations, but certainly I would have a very low threshold to have an upper endoscopy done if there are any symptoms pertaining to the esophagus, heartburn, difficulty swallowing. It's a very safe procedure that can be done in the same session as a colonoscopy, and so I think there's very little downside to having a look there if you have any symptoms or concerns. Many of you are probably aware that the incidence of colon cancer seems to be increasing in younger people, and several groups have revised their colonoscopy screening guidelines to go down to age 45 rather than age 50. If you've had radiation, if you've had GVHD, if you have relatives who have colon cancer, I would strongly recommend a colonoscopy starting at age 45. Or younger if you have colon cancer affected relatives who were younger when they had their diagnosis, and you can individualize these recommendations with either your transplant physician or your gastroenterologist. Lung cancer screening, for a long time we couldn't really figure this out, but it turns out that there is a survival benefit to screening certain people who have a smoking history. So this is independent of the bone marrow transplant. But certainly if you meet these criteria, if you're over age 50 and you've smoked for more than 30 pack years, a pack year is determined by how many packs times how many years. So if you smoke 3 packs a day for 10 years, that's 30 pack years. If you smoke 1 pack a day for 30 years, that's also 30 pack years. So people who meet these criteria, or in our patients, I think a transplant is a risk factor. And so for our patients, it would be age 50 or older and 20 pack years, a screening chest CT is appropriate. And there are some pretty detailed guidelines around these recommendations in various thoracic publications. And your transplant physician should be able to familiarize themselves with these pretty easily. Breast cancer screening is incredibly important, particularly for people who have had total body radiation, certain kinds of chemotherapy, and younger age at transplant. And so the recommendation is to start screening 8 years after the treatment is completed or at age 25, whichever is earlier, but not later than age 40. And there's emerging data that breast MRIs actually will be useful screening tools for people who have had radiation to the chest. And there's a number of publications that support this. They are expensive, and insurance companies sometimes balk at paying for them. So I would really strongly urge you to have a conversation with your transplant doctor about it. Make sure they understand that your insurance company understands that you are at high risk for breast cancer. And so these are both recommended, and mammograms and MRIs, because they provide complementary information, both of them to be done annually. And then cervical cancer screening is really important. I think in the general population, the screening recommendations for cervical cancer are getting less frequent, but there is no data that less frequent pap smears is appropriate for women who are post-transplant, particularly if you have vaginal GVHD. There's emerging evidence that most women, probably, well, not most, but many women are not appropriately screened. Fewer than 40% of patients are getting appropriate pap smear screening. And women with GVHD who are at the highest risk are 50% less likely to be screened. That may well be due to the stenosis that can occur of the vagina. It makes vaginal exams very uncomfortable, but it's still really important to try. So I would strongly urge women post-transplant to make sure they're still seeing a gynecologist or a provider who can do pap smears. There are no specific screening recommendations for these other cancers that I've listed here, but I will highlight that there's a significant gap in our understanding of risk for female genital tract cancers, and this is an area that we really need to understand better. And then I mentioned a few things that you can do for yourself. Be healthier. Don't smoke. Use sunscreen, SPF 30 or higher, and reapply it every 1 to 2 hours. Try to follow a healthy lifestyle with as few processed foods and low fat, high protein, lots of whole grains and fruits and vegetables. Make sure you get some exercise every day. This is important for your cardiovascular health as well, which I know you'll hear more about. And just to say that we're really trying to understand better how to mitigate these risks. And so some future research directions that we've identified in the field is to try to understand the magnitude of risks for specific cancers, to try to understand the interactions between traditional risk factors and transplant-related risk factors. We're trying to do some additional tissue banking so we can try to study risks having to do with inflammatory markers or genetic characteristics so that we can try to personalize our screening recommendations, trying to understand how well our risk reduction strategies are working, and then also to make sure that when appropriate, our patients are getting vaccinated against HPV and hepatitis B after their transplant to try to reduce their risks moving forward. So just to wrap up, I want to say that although this is a tough conversation, no one should regret having a bone marrow transplant. Bone marrow transplants are life-saving therapies. It is far from perfect, but it's the best treatment we have for many, many blood cancers and other very serious diseases. And so it is still a very good therapy, even though it leaves us with a lot to work on still. I really urge you to talk to your transplant team about appropriate screening and make sure you do your screening. Make sure you get these tests done at the right time and don't slack off because the risks really never go away. And so even 10, 15, 20 years after transplant, it's really important to get this testing done. One area that's really challenging is understanding who owns this, who's in charge of making sure that all the testing is done. Is it going to be your transplant team? Is it your primary care doctor? Is it your gynecologist? Is it your GI? Like, make sure that you know who's ordering all these tests. And then lastly, as I mentioned, make sure that you take good care of yourself and make sure that you advocate for yourself. Not every provider is going to understand the special needs of transplant survivors. And so you may, I'm sure many of you are already in a position of having to educate your teams about what transplant recipients need for their health moving forward. So don't be shy about that. So it is a long road, but hopefully one that ends in a great place for all of you. And I will stop now, and I'm happy to take questions.
Thank you, Dr. Loren, for this excellent presentation. We have a number of questions here, so we'll now begin the question and answer session. If you have any questions for Dr. Loren, please use the chat box on the left side of your screen to submit your questions, and we will try to answer as many questions as possible. Our first question is, can Cologuard suffice for a colonoscopy?
That is a great question. So Cologuard is very good at catching cancers, but not precancers. And so there's a whole spectrum of precancerous abnormalities that can happen in the colon that may or may not show up on a Cologuard. And so, and I guess the other thing which I have heard gastroenterologists say is that they want to know about their patient's risk before they have cancer. So yes, a Cologuard is a good screening test for picking up cancers, but it's not as good for precancers. And so I would prefer a colonoscopy. If it's Cologuard or nothing, I'll take the Cologuard. But I think a colonoscopy is a much more thorough and comprehensive test that identifies precancers as well as cancers.
Okay, thank you. Next question is, how does familial cancer history affect your risk for developing secondary cancers?
That is a $64,000 question. I asked that one. We wish we knew. It feels to us that if there's a familial cancer risk that, there are certain familial cancer risks that we can test for, right, like BRCA. And so if somebody has a known BRCA mutation, we would, of course, handle their screening and management just as we would any other BRCA carrier. But there are these more nebulous situations where there's, like, for instance, lots and lots of prostate cancer in somebody's family, but no known gene that we can identify. And so I think in those areas, it really has to be a conversation between the patient and their team to understand, are there additional screening tests or additional considerations that we need to be mindful of. I have many patients that I will order a PSA simply because they have, 5 male relatives who had prostate cancer in their 40s, and so I think they should be screened even though there's no known link between prostate cancer and transplant. So I think from sort of a how does it feel perspective, we all think that those patients are probably at higher risk for cancers that run in their families, and maybe that risk is even higher because of the transplant, but we really don't know, and this is a very active area of research that we're really trying to understand. I think the whole field of genetic risk for cancer is really at a turning point. The more we can test, the more we can understand, but it also adds a lot more questions. So yeah, it's a great question. I wish I had a better answer for you other than it probably matters, but we're still not sure exactly how much or how to manage that increased risk.
Thank you. Is breast cancer an issue for male survivors as well?
That is another great question. It has not been studied, to my knowledge. We do not recommend mammograms or ultrasounds for men for screening unless they are a BRCA1 carrier. There is clearly a risk for male breast cancer in certain genetic syndromes. But otherwise, for men, we don't know, actually, and I've not seen anything published about this, but it is not part of routine screening to consider that. Now, that being said, men have mammary tissues. If they are exposed to radiation, that certainly could be a risk, but we just don't screen for it.
Thank you. There's a couple questions here about annual breast mammogram or 3D mammogram. If I get a mammogram and an ultrasound, is that acceptable, or do I need to get an MRI as well?
The data about ultrasounds for screening is really, really controversial. And I would say that for all of the published studies that we have, no one's really looked at ultrasound as a screening option. So I would go with an MRI if you can. I would not rely on an ultrasound. I would go with an MRI.
Okay. Are all of the comparisons for allogeneic and autologous, can I assume that if I had a haplotransplant falls into the allogeneic group?
Yes, haplotransplants are considered allogeneic. Anything that's not yourself is considered allogeneic. So haplo, cords, those are all allogeneic.
Okay. Are blood or organ cancers more likely after transplant? Do I look to my primary care physician or oncologist for recommended screenings?
So I would say that if you've had a bone marrow transplant, you're very likely to be getting routine blood counts, is what we call a CBC or a complete blood count, as part of your usual visits with your doctor. And I do not think there's any additional screening that needs to happen other than that, which is, again, part of likely your routine cancer care. I do think that attention should be paid to changes in the blood counts. Certainly one blood count being off happens a lot for a lot of reasons. But if there's something abnormal, I would recommend a closer follow-up, maybe 2 to 4 weeks later. And if those changes are persisting, then it may need additional evaluation. Unfortunately, and again, this is not something unfamiliar to this group, the best way to evaluate for a blood cancer is to do a bone marrow biopsy. And so ultimately, that if the blood count abnormalities are persisting, that's usually the next step.
Okay, thank you. Do you think a colonoscopy needs to be done sooner than the 5-year time with colon cancer if colon cancer was the cause of death of a parent?
That's a good question. I'm not sure I totally understand exactly the question. Typically for colon cancer recommendations, I believe, again, this isn't my exact field, but I believe that colonoscopy is recommended starting 10 years before the original diagnosis of the first degree family member. So for instance, if a parent was diagnosed with colon cancer at age 48, their first degree relative should be screened at age 38, regardless of their other history. And so I would probably stick with that, or whatever the more aggressive strategy is. I don't think it matters at what age the parent died. It's more relevant what age they were diagnosed, and then start 10 years before that. And then after the first colonoscopy, the interval is usually based on what they find. So if there are precancers, polyps, adenomas, they may have the person come back in 1 year or 3 years or 5 years rather than the usual 10. But I think that is a more detailed conversation that a gastroenterologist can have with the patient once they've had their first colonoscopy. I hope that answers the question.
Yeah, that's helpful. Thank you. Let's see, next question. My mouth and tongue always stay irritated and sore, but my doctors and dentists say they don't see anything wrong. What would be a next step to try to figure out what's going on?
That's a good question. So I'm glad it's been evaluated, and if they're looking around and they're not seeing anything, that's certainly reassuring. I would say that sort of general irritation or sensitivity is often related to some graft-versus-host disease if this is a person who's received a donor transplant. And I guess I'm assuming that it's a generalized thing, that there aren't like ulcers or sores or anything that's sort of very specific, because certainly viral infections like herpes can cause ulcers. That might be causing a lot of pain and tenderness. But if it's just a generalized sort of diffuse irritation, usually cancers are painless, actually, so I wouldn't worry so much about cancer, but I might be worried about some inflammation related to graft-versus-host disease, or maybe even certain vitamin deficiencies, which are sometimes common after transplant when people aren't eating so well. So I might review it with the oncologist who's taking care of you and see if they have any other thoughts. And then, beyond a dentist, there's a medical specialty known as oral medicine, and that might be another place to try, or sort of a referral to a tertiary center that has an oral medicine or oral surgery specialty for somebody to take a look. They can take biopsies, which I know doesn't sound like a lot of fun, but can be useful. So I would suggest sort of asking some more questions and maybe getting a referral to somebody who has a subspecialty expertise in that area.
Those are some good other options. Thank you. The next question is, should a 70-year-old male with an allogeneic transplant get the HPV vaccination?
It is not recommended at this time for people who are over the age of 45. So the official answer is no. I don't see any reason at this time.
How long are patients generally followed by an oncologist post-transplant?
That is another great question that really varies depending on the practices of your transplant center. So I know that there are some large referral centers who will refer the patient back to their primary oncologist at day 100 or at 1 year or at 2 years. And I think it really speaks to this issue of survivorship as well, and who takes care of long-term survivors of cancer in general. It's a difficult problem, and I think that it's a good question to ask your transplant physician, like what's their usual practice and how do they manage patients moving forward. I will tell you, I'm a little possessive. Actually, I know some of my patients are listening today, so they might be laughing at this. I like to see my transplant patients a minimum of once a year, even if everything is fine and even if they're tired of coming to see me. If they are really, really adamant that they do not want to travel to Philadelphia one more time, then I usually send them with a pretty detailed set of, here are all the expected screening tests. Here's what this person is increased risk for. And I will try to make sure that they have an engaged primary care physician who's really going to pay attention. I think that, as I mentioned earlier, most of the studies that we are recommending are really basic primary care. They're largely things that most people should be doing. It's just extra important that transplant recipients actually do them. Most people, of course, don't follow general health advice, as we all know. And so I think that for transplant survivors, it's just extra important to stick with those good primary care screening guidelines, plus the extra bells and whistles that I usually try to put into a referral note. There are actually medical references that outline in a lot of detail what patients need after transplant, so I'll often provide that reference to the primary care provider. And I think there are also a lot of variations in what a transplant physician is comfortable handling themselves versus not. I myself am not a big fan of prescribing statins myself. I'm not a big fan of managing diabetes myself, and I'm not a big fan of managing testosterone supplements myself. I find those things to be quite difficult for somebody who doesn't do it all the time. And so I'll often rely on a primary care partner to help me with those things, or a cardiology provider to help me with those things, because I want to work as a team and make sure the patient's getting the best care. So you hit on a really sore point in our healthcare system where there can be gaps in sort of who's managing what, which unfortunately requires you, the recipient, to kind of manage and make sure that somebody's doing all of this. And I think having an engaged physician who's willing to have those conversations with you is really key.
That's a great answer, and I think your patients are very lucky that you're possessive. The next question is, I had one radiation treatment after my chemo before my transplant. Is that considered a risk for total body radiation? It was from my neck to my hips.
That's another really important point and something I did not get into the weeds in this presentation. But typically low doses of radiation, which I suspect is what you had, if these numbers are meaningful to you, 200 centigrade, 400 centigrade, those are low enough doses that we think probably it does not significantly increase the risk. But higher doses, generally more than 800 centigrade, and the usual doses for myeloablative transplants are like 1200 centigrade. Those people are definitely at increased risk. So I would say for lower dose recipients, I can reassure you that your risk is probably not increased. But again, most of these screening and preventive practices are sort of general population recommendations anyway, so it can't hurt to sort of at least adhere to the basic screening guidelines for everyone.
Thank you. Next question is, Medicare will only pay for a Pap test every other year after 70, and I am 71. Do you have any suggestions of what I should do?
Write your congressman. And I'm only sort of joking about that. I do think that our healthcare system leaves a lot to be desired, as I'm sure you all, having been through it, would agree. So I think that this is a really understudied area. So if you're a 71-year-old person who does not have HPV infection, who's had numerous normal PAPs, has never had an abnormal PAP, and you're a long time after your transplant and you don't have GVHD, it's probably okay to sort of stick to population guidelines. But that's a lot of ifs, and it's just a guess. We don't really know the answer. And this is sort of what I was highlighting at the end of my talk, which is that women's cancers are significant. Women's health in general is significantly understudied, and women's cancer risk is understudied, and women's cancer risk after bone marrow transplant, like there is nothing, there's no data. And so I think if you're not super duper low risk, I think that your provider probably could appeal and say that this is a special case, and request coverage above and beyond what they normally cover. I don't know how flexible Medicare is about that. Another option is try to work out a payment plan with your provider. If for some reason it needs to be done annually and your provider is not able to get it authorized from Medicare, paying out of pocket sometimes is an option, although it can be quite costly, and so it's not an option for everybody. But it is a hole that we often have to deal with. I have a patient that I'm wrestling with her insurance to get a mammogram approved, and it's just so frustrating. Like, would you rather pay for her breast cancer chemotherapy, or would you rather pay for the MRI? Like, it's absolutely maddening. So I'm really serious about considering letting our elected representatives understand that the needs of cancer survivors are different and important. And there's lots and lots of you guys out there, more and more every year, which is wonderful, but we need to start accounting for that in our healthcare policy.
Totally agree with you. Next question. If someone has reactivation of HPV post-transplant due to immunosuppression and steroids and are over 45, should that person have an HPV vaccination?
So, that's a great question. And I will tell you, I have had one or two patients like that, actually, including one who actually had an HPV-driven head and neck cancer, which I did not mention as a risk, but that is definitely something that can happen both after radiation and HPV. And I shared that person's care with one of our head and neck oncologists, and we did actually vaccinate them even though they were over 45. Again, it might be a little bit of a magician's trick to get it covered, but I do think in that particular situation, it's probably worth trying to get it done.
Next question, how often should upper endoscopy and colonoscopy be done for TBI and GVHD patients?
Another great question that we don't totally know the answer to. My practice has been, as I mentioned, have a very low threshold to send them. Certainly if they're over 45, if they've never had a colonoscopy, if they have any upper GI symptoms, I will recommend both an upper endoscopy and a colonoscopy. Depending on what is found, if there's nothing, if it's completely clean, I think an every 10-year evaluation is perfectly fine, only because we don't know any better. But this is another understudied area that we really need to try to learn about. One of my colleagues at Penn is actually studying this. He has some research funding to look at long-term survivors of radiation to the chest and abdomen to try to understand cancer risks. So for now, I think the key difference is that first screening test with upper endoscopy and colonoscopy, getting that done as promptly as possible. But if there are no concerning findings, is every 10 years appropriate? We don't actually know, but that's the best information we have right now, is to sort of revert to sort of normal screening guidelines if the scopes are clean.
Thank you. Next question. If my original cancer was a lymphoma, do I have higher risk for developing a solid cancer?
Yes. I'm assuming that you have received an autologous, well, some type of bone marrow transplant. Usually they're autologous for lymphoma, but not always. And so the risk of solid tumor is increased in all transplant recipients, but the degree of risk is greater in donor versus yourself. So I don't know if I can go back to my previous slides. I don't know if you guys can see them, but the overall risk of a second cancer is about 2.5-fold for people who received allo transplants and 1.5-fold for people who have received autologous transplants.
Thank you. Though everyone will have access to your slides, so they can absolutely take a look. Yeah. What is the criteria for distinguishing the reception of an auto transplant versus an allo transplant, or why does a patient receive one over the other?
Right. That's another really good question. So people who have cancers that are sensitive to chemotherapy and can be cured with chemotherapy will often receive autologous transplants. So in the current era, that largely means people with myeloma and people with lymphoma. People who receive autologous transplants for myeloma, it is still not curative, but it can significantly extend life expectancy and reduce the risk of certain complications like fractures and kidney disease. The role of autologous transplant in this era where we have so many really advanced and powerful therapies for myeloma, I think remains to be determined. For lymphoma, it's also getting more complicated. Autologous transplant used to be the first choice for people who had relapsed lymphoma after an initial round of therapy, usually for people who have either Hodgkin's or diffuse large B-cell lymphomas. But now with CAR T cells, that role of autologous transplant as the second line is being called into question. And CAR T is now, as many of you know, I'm sure, FDA approved for second-line therapy for diffuse large cell, although not for Hodgkin's. Hodgkin's, it still remains an important second-line choice. People who typically have cancers of the bone marrow itself, like acute myeloid leukemia, myelodysplastic syndrome, acute lymphoblastic leukemia, myelofibrosis, those are bone marrow cancers. So we can't use that unhealthy bone marrow for a transplant. So those people need a new bone marrow entirely. They need somebody else's blood cells. So that typically is the way that we decide, but there are exceptions to all of those. T-cell lymphomas, it's very controversial whether to do an autologous or an allogeneic, and it often depends on the disease and the health of the patient and the donor options. And similarly, there are rare circumstances in acute myeloid leukemia where we might choose to do an autologous transplant using your own cells. So this is by no means a one-size-fits-all answer, which is sort of a very general kind of sense of how we make these decisions.
Thank you. Next question is, have you seen marked differences in treatment responses to secondary cancers of people who have had transplants?
That's another really important question, and I would say that the answer is yes, which is why the screening and prevention is so important. So I certainly do not need to tell this audience what you've all been through in terms of how much therapy and how much it takes out of you. And so it does get harder to get through, for instance, chemotherapy for breast cancer or chemotherapy for colon cancer if you've already had a transplant. And so I do think that the toxicities are greater. It's just harder to get through treatment. I don't think we know if treatment is more or less effective, but what I do know is it's harder on people. And so what that sometimes means is that the treatments have to be modified or reduced or attenuated because the person can't tolerate them, and that might then impact how well they work. So I do think that it is harder for people once they've had a transplant to go through treatments for other cancers. But I will tell you, I take care of a lovely patient who had a bone marrow transplant 25 years ago when she was 20 and included total body radiation. And she just recently had a breast MRI that revealed a stage 1 cancer. And so all she needed was surgery and hormone therapy. Like, thank goodness. Like, otherwise, if we had not found it, it might have been a much more serious situation that would have required higher intensity therapies. And so I do think that that's why we sort of really push people to sort of adhere to these screening and preventive practices, because if you can find it early, the likelihood of needing those risky therapies is much less.
Thank you. And this will have to be our last question. What is the role of Rezurock in helping with chronic GVHD and or in turn reducing the chances of secondary cancer?
So Rezurock, as many of you know, or also known as belumosudil, is the most recently FDA-approved therapy for chronic graft-versus-host disease, and it is a very effective form of treatment. I think what the person is asking is, if you treat graft-versus-host disease, does the risk of cancer go down? And so if that's the question you're asking, that's another $64,000 question that we don't know the answer to. It does stand to reason. You could sort of, I'm actually thinking of this as I'm talking to you, you could argue it either way. You could say, well, if there's less inflammation and there's less damage to the organs, the skin, the mouth, then maybe there's a lower chance of cancer. But we also worry about immune suppression, which all of these medications that treat GVHD ultimately do lower our immune responses a little bit, and that can predispose to other cancers. So I don't think it's going to be a straightforward yes or no or up or down risk. I think it's complicated. And a lot of our endpoints for treating graft-versus-host disease have to do with symptoms, like how is the person feeling? Is their range of motion improved? Are they feeling better? Are they able to do more physically? We're not asking questions about cancer risks and GVHD treatment. We should be. That's actually a great question and a great point, but we don't know the answer to that right now.
Okay, unfortunately on that, we will have to end it, but I'd like to, on behalf of BMT InfoNet and our partners, I'd like to thank Dr. Loren for her very helpful presentation, and thank you, the audience, for your excellent questions. And please enjoy the rest of the week of symposium workshops.